All right, well, hello, everybody. I'm Dan Polsky, Director of the Hopkins Business of Health Initiative. Welcome to our webinar series, Conversations on the Business of Health. This initiative brings together scholars from across the university who share a vision of advancing health through an affordable and equitable high-value health system. In pursuit of this vision, our work focuses on the role of business in advancing health and healthcare and incentives through rigorous, objective, nonpartisan, interdisciplinary research. So what we try to do is create a space to see common ground from different perspectives as we try to understand the relationship between business and health. Today's webinar, Common Ground, Organizational Objectives and Employee Health. I want to welcome you all. Our ground rules here, we go until 1. Please feel free to use the Q&A function and we'll do our best to respond to questions. I'm now going to turn the proceedings over to our moderator and the creator of this exciting panel, Michael Darden, who's a professor at Johns Hopkins Carey Business School. Michael?
Thanks, Dan. Yeah, great to be here. So welcome to Conversations on the Business of Health. Like Dan said, my name is Michael Darden. I'm an associate professor of economics at the Carey Business School at Johns Hopkins. And the title today is Common Ground, Organizational Objectives and Employee Health. So just to set the scene, 2 weeks ago at another HBHI webinar, my colleague, Maria Machis, led a fantastic discussion on corporate social responsibility in health, in which they discussed the extent to which corporations bear praise or responsibility in some cases for the health implications of their products. And the discussion was motivated by this idea that in many cases, health is produced outside of the medical system. So what we consume and how we spend our time in many ways is more important in the long run health, for long run health than the interactions with physicians. So our discussion today is gonna revolve around a related question, and that's to what extent do corporations and employers or organizations more generally prioritize employee health or member health, and how much of the variation in health in kind of a population sense can be explained by variation in work, the tasks that people perform in the work environment. And I think this is a really fascinating time to discuss these issues because we've just experienced this major shock in the labor market in COVID-19. So, as we work from home more and more increasingly, we have all of this within individual variation to think about how the work environment affects health and how work affects health. So to discuss these questions, I'm really excited to bring 2 renowned experts, Colin Espy and Amy Adler. So Colin is an internationally recognized scientist who specializes in clinical and laboratory assessment, treatment of sleep disorders, and particularly in the context of cognitive behavioral therapeutics. He's a professor of sleep medicine in the Nuffield Department of Clinical Neurosciences at the University of Oxford. And especially relevant to the discussion today, he co-founded Big Health, which is a company whose mission is to help millions back to good mental health by providing safe and effective non-drug alternatives for most common mental health conditions, including insomnia and anxiety. So Big Health has created these digital cognitive behavioral therapies, which they market to large employers who offer them to their employees. Amy Adler is a clinical research psychologist and senior scientist with the Center for Military Psychiatry and Neuroscience at the Walter Reed Army Institute of Research. She's authored more than 170 articles and chapters and edited and co-edited 7 books, including Anger at Work. So Dr. Adler's research focuses on developing easily fielded emotional regulation techniques and examining the role of leadership in behavioral health. So I'd like to welcome them both and thank them for joining us today. To start the discussion, I really want to start at a very kind of big picture, high level, and just think, to what extent we should really expect that there's health promotion at work. So Colin, let me start with you. I'm going to paint a very kind of econ 101 picture of health in the labor market, and perhaps you can offer some context and nuance here. So, the traditional view of corporations and employers is that their only objective should be to maximize shareholder value. So employers want employees to be sufficiently healthy, but only really to do their jobs. And that's kind of the traditional view, the Milton Friedman view, going back several decades. But I wonder to what extent you think there are win-win situations in which employers that have organizational objectives like profit can also improve health in their employees while also improving their bottom line.
Yeah, thanks, Michael. It's great to be part of the. Thanks, Dan, as well, and appreciate being invited along to participate in this business of health. I never expected myself, career-wise, to be involved in the business of health. It was a somewhat surprise to me, actually, when I founded a company about 12 years ago. Kind of having a very clinical academic background, because I always thought that being involved in business or industry was kind of like joining the other side almost. It was a little bit like, well, I'm an academic. Other people do the business, but I do the pure research and evidence-based piece. But having crossed that Rubicon, I realized that there's a lot of people who are very like-minded, and they just don't want to do good work. And to your point really about employers, and your earlier mention of variability, I think there is a lot of variability out there in the extent to which organizations go beyond their code of conduct that's on their website, which often talks about valuing people, but do they actually do it? What I would say is when they do it well, it makes a big difference, because the incentives really are aligned. If you want to be successful with your business, have a healthy workforce is very consistent with that. And the people who deliver into that healthcare system, like we're doing with Big Health, for example, the incentives are also aligned for them, because you're providing something that's valued by the people who are receiving it, that pays benefits to the company, because the main asset of most organizations is actually the people. There are other assets, potentially like buildings or equipment or things like that. But most organizations can't function without people. So therefore, it does make sense that we should invest in people. And indeed, that was our primary entry into the healthcare market in the States, was working with self-insured employers for whom those incentives were quite clearly aligned. Because these are companies that fund benefits for their staff and provide healthcare schemes for their staff as part of their package. So in these situations, the benefits given and the benefits received often seem very well aligned, both in terms of physical health and mental health.
That's great. And I hope we can talk a lot about mental health going forward, because it seems like a really ripe area within this context. But I'd like to turn over to Amy and get her thoughts, especially from a perspective that's very potentially different than a for-profit company.
Yeah, so thanks also for the invitation, and it's just really exciting for me to think about the lessons learned that we have in the military, how they might apply to corporations or organizations. Because as you mentioned, we're coming at it from a very different perspective. In the case of the military, for example, which I don't think is the case of an organization, typically like a business, there is an understanding that our individuals are potentially put at risk. So there's an understanding that by doing their job, they are potentially at risk in terms of their own physical health and even in terms of their mental health potentially. So if you go into thinking about this question from that perspective, it sort of changes the entire way that you're going to look at it. So for example, in the military, there are also two main thoughts that drive the decision making that they have. The first is that it's actually even in that I work for the Army, so I tend to think of everything in terms of the Army and not just the other services, but it applies to other services as well. But that is that soldiers look after one another so that you don't leave a fallen comrade. It's not just something that's written, you know, on a wall and just sort of tacked there, but it's an essential part of the whole culture. And the other piece that's an important thing to consider is that there's a psychological contract that exists for people serving in the military, so that if they are hurt or injured in some way, there's an understanding, both explicit and implicit, that they and their families will be taken care of. And so that's already part of the way in which the military thinks about hiring individuals and putting them potentially in harm's way. And I think because of that, there's really a focus on prevention and on early intervention, and also treatment, although typically there's also this, you know, this if the person leaves the military, the VA would pick up, an entire different agency would pick up from that. So it kind of has, there's a lot of moving pieces. The other thing that I would say is that there's also a very clear emphasis that the organization itself needs to be able to support the individual. So it's not just the individual working in isolation, but that the role of leaders is central to the well-being of that individual. And so we develop programs very specifically around how leaders can help those service members who serve in their units.
So for either of you, I would like to kind of drill down a little bit and just kind of think about what specific types of domains of health are particularly affected by workplace incentives or workplace health promotion or wellness or things like that. Colin mentioned both physical and mental health, but maybe we could talk about some specific types of health. Colin, maybe you could start, and then we'll just go back and forth.
Yes, I think often you know, from my perspective, the best way to approach this is how do you enable somebody to look after their own, you know, and rather than you know, being thinking of it like a didactic thing. You know, it's very much about how do you enable somebody to take an opportunity to look after their own health. And so, for example, one of the things that we have done with organizations, and of course my background is in sleep research, and so we've sent out round the organization, hey, how are you sleeping? Need any help with your sleep? Because you know, that is a kind of call to action that's actually interesting and not particularly threatening for people, but it can be like a Trojan horse into asking questions then about your mental health. Whereas if you say, hey, any dependencies you need help with, or how's your mood? You know, how's your weight management going? You still going to the gym? You know, it's easy to approach health from the ministry of no being critical of people, ministry of no fun, stop smoking, stop drinking, don't do this, don't do that, don't do the other. Whereas, you know, engaging in a topic that's of interest to people is a way and then to broaden the conversation. So that's an example of what we do at the moment in many organizations in the States is we put out these public comms through the organization itself. People then take a sleep test, which is just a few questions. They may then go to a webinar where we talk about what is sleep, why does it matter, and how do you improve your sleep? And that could then be, hey, what about your 24 hours? How are you feeling during the day? Do you sometimes get anxious? Need help with that? So I think my answer to that question really, Michael, would be that I would encourage organizations at all levels to think about this as a partnership, not a kind of directing people to things, not just as a public communication of science, but as an active engagement in self-care promotion that is, that finds access points for individuals. And that's where our experience has been the strongest in this area, because a lot of public health medicine is very propositional, and it's just providing people with information, and people often don't know what to do with that information, or they remain intentional but don't actually get to an action phase. So we try to lower the bar by having a range of offerings that are accessible to people and are intrinsically non-threatening.
Great, Amy. When you think about the military, are there other examples like that where there are interventions that are kind of self-reinforcing, that helping people help themselves, and kind of teaching tools and that sort of thing?
Yes, in fact, I was going to say first, in terms of health on all levels is a critical priority for the military, because it's dependent on people being physically able to do the job and to be able to withstand the rigors of, military operations. So there's a huge emphasis on physical health, on brain health, mental health, so rather than talk globally about this, I'd love to zero in on the topic of sleep. I'm not a sleep researcher, but I work with an organization that's does some of the primary sleep research for the Army, and at my organization, Walter Reed Army Institute of Research. And we've partnered together to think about how do you get information about sleep, because I really agree with Colin. It's a wonderful topic to start with, because it drives so much in terms of brain function, decision-making, performance, moral reasoning. There's a host of reasons why you'd want to emphasize sleep. And we take a slightly different approach, because of course we promote good sleep hygiene just at the individual level, but because individuals function within teams and we're in a very hierarchical organization, we provide information to leaders who really set the conditions for service members and their sleep habits. So we've developed training, for example, and we ran a randomized trial a couple of years ago where we developed training for platoon leadership teams. So that's a first lieutenant, for example, and their equivalent on the enlisted side. And we provided them 1 hour of training in just how do you think about sleep, why is sleep important, and as a leader of a team of, let's say, 20 or 30 people, how are you going to set the conditions and encourage and educate and lead by example and prioritize and plan that will help that individual sleep more. And we found that even 6 to 8 weeks later, service members in their units were actually sleeping more, and they also noted that there were changes in the behaviors of their leaders. They were more likely to say that leaders were engaging in these positive behaviors. So when we think about health promotion, we think about it from the perspective not just of the individual, but of the entire organization, because it's such a hierarchical organization. So I hope that's helpful.
Yeah, no, very.
Maybe I could just amplify a little point there. But that's really interesting, Amy. But I think one of the things that I think attracts members or employees to take things seriously, and also for employers to take things seriously, is to see that there are mutual responsibilities. So for example, when one thinks of stress or disorders that relate to stress, the stress axis, anxiety and depression possibly, and certainly insomnia, there are aspects of the job and what you're asked to do that are stressful, like working shifts or working in dangerous environments if you're in the military. And there are aspects of it which are more to do with how I manage the situation myself. And I think there's an honesty there, recognizing that there's things that you can do to help the situation, but there's things that possibly we should be doing as an organization to help you. Then that leads to a more authentic engagement.
If I can just build on that comment, the other thing I would say is, sure, I talked about platoon leadership teams, but leadership matters all the way up the chain. And we don't just start with platoons and say, okay, good luck with that. Obviously, it has to be embedded within a larger system. The other thing is, as you're engaging the individual, if the individual isn't as keyed up to learn or keen to learn about whatever it is we're talking about, if we're talking about health promotion or resilience building, one way that's very effective and culturally consistent for us is we talk about, hey, you may not need this for yourself, but your battle buddy might need this, your mate might need this. So there's a great deal of willingness to listen in, because they understand they have implicit responsibility to support their battle buddies and that they're mutually interdependent.
One thing that I really picked up on there from both of you is that data is really important here. So Colin started by saying, well, we're going to offer a survey that's not very intrusive, right? We're going to ask you about your sleep, your sleep. How are you sleeping today? But that's a data point that's actually quite valuable. And then Amy said, maybe 6 to 8 weeks later, there's some outcomes where you could actually see these kind of improvements in sleep, really translating. So one question that I have in the context of leadership is how do you collect the data on employees in the context of sleep or other health conditions that is convincing to leadership that this is something we need to keep going with? Either of you.
Yeah, well, I mean, I guess the terminology that's often used here is ROI, return on investment. And the conversation needs to be about what is it that you care about, what is the outcome that matters to you, and I think sometimes ROI is a terminology I was originally quite uncomfortable with because it sounds very much like a financial equation. But actually, when I thought about it, it's kind of what I do in my clinical work with patients. Is I say, how would things be different if you didn't have this problem? You're kind of, and you're trying to figure out what the outcomes are that matter, and therefore so if that's what you're trying to achieve, then these are the things we need to address. So you begin to get that equation together. So I think these are all to do with data points. First of all, what is the variable that matters? I think that's the key thing. And then how do you measure that variable? We're agreed on whether or not it's making a difference. One of the things that we have done in the business is work with employers and their company culture and their goals, to establish what that ROI is, because it isn't always financial. It may be to do with employee satisfaction. It may be to do with retention. Things that can be measured ultimately in dollars, but actually begin with more people-related outcomes or that kind of thing. And we have an ROI calculator that we use in partnership with organizations to help them figure out what it is they want. Because sometimes people, I want to do something, but they actually don't really know themselves what the outcome is that they care about. And then, so you work in an endeavor without ever establishing that. And then in the end, you're not sure what, because nobody's the point we're measuring. So I think it is hugely important to do the diligent work around establishing what are the outcomes that people care about, how do you measure them, and are we making progress? And to be frank, if there's no evidence against those ROIs, then it is a waste of money.
Amy, do you have, I'm sure in the context of the military, data is central, so
Yes.
talk a little bit about that.
Yeah, I also was thinking about the phrase ROI, and clearly, in a business setting, that it's all, you can break it all down into cost or very specific measures of productivity. Although I would suspect that even in a business setting, it's actually harder to do that than it sounds. I just, rattled that off, but then the dangers in the details, right? In terms of what does it actually look like? In the military, it's the same thing. We're always looking for measures of performance and readiness. And it's like the holy grail to find something like that, and it's very hard in research to find good outcomes that are just, absolutely address all potential problems and demonstrate value added, the added value of particular intervention. So we take sort of a piecemeal approach. So in the case of sleep, the sleep study, for example, we were able to show that sleep could be impacted. Although I do want to point out, there's still plenty of room for improvement. It's not like we walked away saying, okay, we've solved that problem, let's move on to the next one. It's, this to really get sleep right requires a kind of a much larger, more involved set of solutions. But then we have separate studies that show that sleep matters in terms of decision-making, in terms of actual performance when it comes to weapons qualifications, things like that. So we've been able to, sometimes we have to show the pieces and as a chain, if you affect this, and we have another study that says, okay, this matters in this way. But sometimes we're lucky and we're able to see, for example, we have a lot of work that we're right now doing on mindfulness, which is, a popular and common way of improving emotion regulation and attention and working memory. And we can do measures of neurocognitive performance, but of course, service leaders really want to see also that extra connection of, can you show that this is going to make a service member more better able to perform in under high stakes conditions. So we recently published a very small study showing that the more a particular group of soldiers practice mindfulness, the better they were able to perform on a stress shoot. So where you do physical exercise very rapidly right before you actually do some sort of weapons qualification test. So we were able to show a very direct link, and showing links like that, even if that's not the only thing soldiers do, it's very helpful in showing, yeah, there is a clear link between mental functioning and performance in this very concrete way. But then there are other times where senior leaders are interested in other kinds of topics. They're interested in mental health as the outcome. Certainly, probably many people on this call are aware that there's a lot of concerns around mental health when it comes to the military, both in terms of handling the stress of combat and also just in terms of suicide and depression and anxiety, topics that are really reflected in the civilian world right now as well. And so in that case, senior leaders are happy to see if we're able to impact depression or anxiety or self-reported resilience or sense of flourishing and a sense of purpose to what you're doing. And we do have some studies right now that are able to demonstrate some of the interventions are having an impact on those outcomes. And we're not showing direct impact on some concrete performance metric like a tank crew in performing a gunnery exercise, where we have some studies showing that. But in this case, even just showing that there's a change in attitudes as measured by a survey matters to senior leaders. I can give you an example about that if that would be of interest.
Great, yeah. I just want to hear from Colin really quickly about the kind of parallels in the corporate world and the extent to which you said earlier that it seemed that, like different employers want different things.
Yes.
But maybe a common theme would be they want better productivity. They want their workers,
yes.
Right? So are there ways that you can kind of measure that, or like in the context of what Amy was talking about, physical stamina or physical performance or marksmanship or something like that? Those are very measurable. But in the corporate world, sometimes it's less obvious what that is.
Yeah. So I mean, this has been a learning point for me in my career. And Michael, you've been very helpful to us as we try to think about how you move from what traditionally have been clinical outcomes. So someone's got sleep problems, so can you improve their sleep? Someone's got depression, can you improve their mood? The very immediate things which are part of the presenting condition, to, well, what difference does that make to somebody's life? Are they actually any better? How do you know they're any better? And are these just subjective ratings of things? So the kinds of things that we've included in our studies, we've completed 13 randomized control trials, many of them very large trials, over the last 10 years or so. And now we're increasingly incorporating health economic analyses into those. And that is also informed not just by the grant awarding body saying, have you got a health economic analysis, which seems to be added in routinely now to almost every grant application without perhaps even the funders knowing what they mean by that. But being informed by the industries, it is things like constructs such as presenteeism. So someone can be at work but not really productive. It could actually be literally absenteeism. It could be, can we show differences in claims data? So we have done a white paper study where data were analysed by a health economist from Stanford, looking at the claims data from a large organisation, showing that by intervening, you made a difference to the healthcare costs for that individual. It could be using more of a standard measure like a quality adjusted life year. Again, database, we just recently published or are about to publish a study on this based on a trial that was published in JAMA Psychiatry, looking at does it actually improves people's quality of life, if you like. And a nice guideline in the UK that we got recently, actually, it refers to sleep yield being cost saving in healthcare, not just cost effective, but also cost saving, based on analysis that were done independently by the NHS in the UK. So as I was saying earlier, it's really important to understand what are the outcomes that matter for people, whether those people are the end users or whether those people are the, if you like, the commissioners or the purchasers of care. Because in most cases, the patients want you to help them, and they want to, want you to be able to deliver things that can benefit them. And likewise, when it comes to a more commercial agreement, the company want you to be able to demonstrate benefit, back to the original point, which is about incentives at some level being aligned. They want to be able to see there is value for their investment, because they're often more like partners when it comes to figuring out, how we're going to implement this in our organization.
So I want to take one position that's the devil's advocate here, and one complaint about employers or organizations focusing on health or investing in health is that it's just lip service. They don't actually care about health. They don't actually care about their employees. What they care about is being defensive against kind of litigation, or when bad things happen, they can point and say, look, we do have these resources for employees. Have you found that to be a problem, that are one of the rationales for investment in some of these products, or is that something that by and large is not relevant?
Yeah, is that a question for me, Michael? Or
sure, yeah, we can start.
Yeah, no, I think you're right. I mean, I said at the beginning that that there's a spectrum, right? There's a range of motivations. There's a range. There's good and bad in everyone. There's good and bad in every organization, and I think I think what we need to do is to work towards establishing a duty of care, which is a mutual thing. And if an organization is engaging in lip service, without taking moral high ground, I suppose what I would hope to do is to how do you convert that lip service into a duty of care, which is at least a contract, if you like, somewhat of a moral contract, perhaps, then into an enthusiasm which makes people greater satisfaction in their work. There's a lot of people on their knees in industry. There's a lot of people on their knees in healthcare and public services because they're overworked, often underpaid, and of course, been under a real and existential threat over the last couple of years. So I don't think we can expect people always to be, highly motivated and front foot. So I think, we need to take people at the point they're at and help them move towards a better place. And we need to publish, and not just in the scientific literature, but we need to publish case study material of things working well, and have advocates, if you like, for investing in people, and that organizations are proud to be seen as good employers, and that's also something that incentivizes them to maintain those high standards. In the end, though, Michael, I think it is down to leadership rather than management. We need really good leaders in industry, in all organizations, because leadership is about doing the right things, and management is about doing them well. I think sometimes we have a lot of management, and it's not necessarily doing the right things. So people spending a lot of time kind of doing things that are kind of half right, and that's where we see a lot of failure. And it's understandable that a lot of employees can be cynical about their organizations, but other employees can be very proud of their organizations. We need to try and level everything up so that we're all performing better.
Amy, I have one question from the chat that I think follows nicely from that. It's talking about, you know, the very high rates of suicide in the military or mental health, or as Colin was talking about, burnout, and the fact that so many people are, you know, on their knees, as he says, are very desperate in difficult situations right now. And I think the spirit of the question in the chat is basically, you know, should we be thinking about employers, or the military in this case, as the entity that's responsible for this, or do we need policy solutions that are of a much higher order of magnitude?
So I'm not sure what is meant by policy solutions that would exist outside of the military. Can you expand on that a little?
Well, I mean, I think more just like social, social, yeah, you know, for example, you know, the extent to which CMS treats mental health differently, or the way we think about just investment in community more generally.
So I have a few things that I'd like to add to that. First, there's a really good book by Craig Bryan that is about rethinking suicide. And in particular, he focuses on suicide in the military. It came out, I think, about a year ago. It's really a very valuable take on thinking about suicide in the military, not just as something we want to try to screen our way out of, right? Because we know that that's not going to work, but really taking this larger upstream approach, you know, creating a life worth living, and creating sort of the foundational skills to help people be able to navigate and realize that, you know, just the desire to kill themselves also occurs typically in a very short time frame between the thought and the act. It's much shorter than we originally researchers had thought and assumed. And so that kind of approach shifts the way the interventions would look. So I think it's a great idea. I think kind of we need an all hands on deck approach. I guess that's what I would say. So I think we need to be thinking about this societally. I think, you know, the U.S. military is a reflection of the larger U.S. society. The problems that we see in the larger U.S. society are not somehow screened out when people enter into military service. And yet this organization, which has then taken on these people and has this psychological and actual contract with them, also bears responsibility. At least that's my personal opinion. So I think all can be true. The other thing I wanted to just reinforce, I love that Colin said the thing about it's not enough to have the organization be in on it, but you need leaders to focus on particular methods for unrolling or supporting programs. In fact, some of the work we've done shows very explicitly that very specific leader behaviors, really concrete, specific behaviors, not transformational or complexly defined behaviors, but like, do the leaders show up to the training, for example, let's say if it's resilience training or wellness training, do they show up? Do they talk about it? Do they emphasize it? Do they talk about the impact it's had on their own lives? If they engage in those very simple behaviors, then soldiers get more out of the training, even after you control for, hey, this guy's generally, or this person's generally a good leader. And I think that added benefit of something very specific and concrete is something that we are trying to think about. And I want to mention that for us, especially for junior leaders, I don't know how this would be parallel to a business organization, because in the military, many people get an opportunity to lead. And so we don't, and they come in, they're very young, they're not necessarily ready for big transformational leadership ideas. And we're trying to break it down to very specific behaviors that they can engage in to see if we can kind of use that as a way to have these interventions or prevention programs or resilience training kind of be more impactful in the long run.
No, that's great. Yeah, fascinating. I mean, I think there's a discussion in the chat that's going on that I think is paralleling this really nicely, which is, Amy's talking about leadership and being so important and specific things that leaders can do. But the question in the chat is a little bit more about one way you could think about investing in employee health is by changing leadership or by investing with like wellness programs or something like that. But like another one is changing the nature of the work. And so maybe in the military, that's that's not as easy to do, but in some contexts it may be. And so maybe Colin, I don't know if you had some follow-up thoughts on that distinction between the nature of the work versus the kind of benefit side or the cultural side of the organization.
Yeah, I mean, I think traditionally, in the long-established industries, you have bosses and employees, and it seems almost like a confrontational system. So terms and conditions, workplace environment, the stresses you put on me. I need a union to represent me, because the way I'm feeling and the problems I have are your fault. And then the other way around, well, I expect you to turn up fit and healthy for work, otherwise I'm not paying you. So you need to sort out your problems. I'm doing my best to provide you with benefits. I'm doing my best to provide you with resources. And that's a very oppositional system. We need to recognize it's in the interaction of things in life that often the problems arise. And I think that's where we need leaders to understand that. The military is probably a very good example because there's some inevitable stresses, right? They can't be overcome. But equally, if people are working night shift, night shift, we're not, most of us aren't natural night animals, right? Some of us are, but most of us aren't. So there are real stresses there. I think what we need to do is think about this in how we can find accessible solutions that we can begin to try out rather than making a kind of standoff or a debate. We need to get action on this. Certainly in relation to the things that we do with the workforces that are funded by the organizations. We develop digital therapeutics that are very accessible. You can immediately access them on web and mobile, and you can put them in practice for sleep and anxiety and other problems like that people can use. But we also find that many of the managers use them, many of the senior people use them, because they're also employees. We sometimes forget that. We think it's very much in us and them. And then when you get leaders saying this really helped me, or acknowledging I've got a problem with this, they also realize that in the boardroom, this company puts huge stress on me because of the way my colleagues are behaving. And it does help for people to reflect on the situation is actually broadly the same for them. And in other parts of my working life, I also do quite a bit of work with organizations at the leadership level to help them reduce the organizational stresses which are causing problems in the first place, like looking at shift patterns, work patterns, and indeed I've done a little bit of work in that regard with the military as well. So I think it's about addressing both of those things, and trying to recognize viewpoints that people have, and often it does involve bringing people in from the outside to be the honest brokers of that, because sometimes it can be too confrontational in the workplace itself. It's a really great question, as I said earlier, I think the more we can celebrate examples of cultures where it works very well and try to emulate them, and publish that information, the better. I think as academics, we traditionally don't publish things that are based on real world examples, and more real world evidence is needed, I think, in this area.
Do you think that that interventions in the workplace have the potential? You spoke a little bit about the kind of accessibility of some of the products that Big Health produce to address some of the health disparities in society. So when you think about the gradient in health between across racial lines or across socioeconomic lines, it's pretty steep in some cases. Does the is the setting of a business the appropriate place or to think about those disparities, or is that a place where there's a lot of marginal value in investments in health? Maybe we can start with Amy and go back to Colin.
I think the question of health disparities, which is so important, is certainly in the US culture, and I think others as well, is I'm probably not ideally suited to address the question because of the way the military is structured, based more on rank and type of unit. Those are probably the variables that matter more for us when we're predicting something. So I don't know that because this is everybody has access to healthcare and everybody, there might be implicit bias that we haven't tapped into. That's possible, but as an organization, historically, it's kind of been more on the, ironically, more on the forefront of social change than one would expect from just thinking about this as a very conservative institution. So I'm probably not the best suited to address racial or health disparity research.
Colin, what do you think? I mean, in the context of the UK or the US?
So for, well, in the UK, I mean, healthcare is free equally to everyone, regardless of status. There's no, but that doesn't mean it's as accessible. It may be free, and people will not have to pay for it, but they don't necessarily know about it, or they don't necessarily have the means of transport to get there, or may in circumstances where they can't take initiatives, for example. So I think one always has to be addressing issues of equity and diversity and inclusion. All these things need to be actively managed, even in situations where access to healthcare is universal and free. And that doesn't immediately just solve it in a stroke, as it were. I think we're very conscious in what we're doing, in Big Health, in trying to see ways in which, by providing fully automated digital products, that they can be very accessible to people, because you don't need to go to hospital to get them, etc. You can access them on your phone or whatever. And then most people, or many people, have mobile devices, but they may not have bandwidth, things like that. Or if they want to, follow things in, on a laptop or whatever, they may not have a laptop. So you're then just navigating other questions like, can there be community resources where people can access the programs? Can they go to a place where there is free Wi-Fi? Can they be provided with bandwidth as part of the benefits plan, or whatever? And try to reduce those disparities as much as possible. And we certainly work with organizations to try and identify with them, where people are going to be excluded and how we can try to find ways of them being included. I'd like to think, in a way, this is a problem we never solve. That may seem a strange thing to say, but I think intrinsically in society, there's always going to be a problem of equity. But I think to address that, to be consciously aware, the likelihood is that there always will be disparity. So therefore, one needs to keep actively looking for it and trying to address it, rather than thinking, well, we had a policy, we had a program, we addressed it, we did that last year, this year we're doing something else. I think we have to keep it front of mind.
Yeah, that's a really great point. I mean, I was actually going to bring this around to thinking more of the long-term aspects of some of these things, and maintaining the incentives to continue creating this culture, the trust, the kind of leadership environment within an organization that's required over long term. So related to that, the workplace has changed enormously over the last 50 years in terms of just technology. And Colin is highlighting how their company has come in with digital therapeutics that perhaps expand accessibility to some benefits. But Amy, do you think it's more or less difficult to promote employee health in the modern age than it was, several decades ago?
I think it's both harder and easier. I guess I'll cheat and just say that. It's both are true. I think for one of the things I think about as a researcher and somebody who helps develop interventions and trainings is I'm always concerned if people say, oh, the solution is an app, and then they just say, okay, we're done and we've solved the problem by having an app. I think apps are a piece of it, and they're important, and some people are probably more oriented towards using apps than others, but I think we have to be careful not to sit back on our laurels if we've developed an app and say that we've accomplished it. It has to make sense within the larger culture, and it has to make sense within the certainly in the military where teams matter, you know, how is it being leveraged to support the health of the team and the functioning of the team, and how is the team and the leadership ensuring that the app is still being used and still relevant. And, you know, I think of all the ways in which this stuff can just end up sitting on a shelf, basically, or sitting on someone's phone and not being used. So that's one thing I think about, but I do think it's really a great opportunity to be able to leverage it. And so we just want to leverage it with kind of thinking in mind how we can get the most out of it. The other thing I want to just add is we're in the middle of having of finalizing a study where we looked not at an app, but at individuals meeting with a military and family life counselor. So these are credentialed therapists who work outside of the medical system. There's no medical record. They just are freely available. They're located on every military post. And there's a requirement in some units where no matter what your rank, you get to go once a year and just have a conversation with a human being, with one of these counselors for 30 to 45, maybe 60 minutes, where you talk about what matters to you. And the goal of this program is to sort of break down barriers and worries around what counseling is like, but also potentially to build resilience and to maybe get some tips, some tailored resilient skills, if you will. And I think it's almost like the antithesis of the technology solution. And we're finding that soldiers who have gone through one of these wellness check sessions actually report better adjustment afterwards than those who haven't. And we tried controlling for a bunch of things. It's not a perfect randomized trial, but it's some sort of comparison is able to be made. And I'm fascinated that this low-tech solution, this person-centered solution, is something we also need not to forget. So we do app development, but I also like this person-oriented solution as well.
Kala, do you see complementarities between your products and perhaps low-tech solutions that are?
Yeah. I think it's really, at the moment, there's a lot of confusion, I think, when people talk about apps, there's apps for everything. I think we need to begin to recognize that there's a difference between well-being and health. So let's take mental health as an example. The variations in our mood, our occasional sleep problems, sometimes feeling worried about things or down or distressed, and needing some way of addressing our well-being and keeping ourselves mentally healthy, is really. But there are also people who are depressed, who've got a clinical problem with insomnia, who can't function because of their anxiety. So I think there's a spectrum there, and we need to recognize that apps, I'll go to the App Store and find something for that, is a bit like saying to somebody, why don't you just go down to the drugstore or down to the, and you pick up some pills down there. There's a whole range of stuff. There's pills and there's pills. There's things you can buy that are not necessarily treatments. They're not necessarily, you're free to buy them. They may help you. But that's a wrong investment to be making if you've got a clinical condition. You should be getting clinical level help. So you get pills, and people understand there's a difference there. We need to begin to understand in the digital world that there will be a difference, and there's a difference between apps and apps. There are ones that are evidence-based, treat a problem, make a difference, and have got clinical outcomes with trials evidence. And there are things that are really just marketed as, and often that's in the well-being area, nothing wrong with that. But, I think we do a disservice to the community if we direct people, just to, to find a solution when they have got a clinical problem. And I think when organizations are providing perhaps through their benefits management piece, through the human resources piece, programs for employee well-being, that should not be confused with people who need still to see a doctor, who still need to see a clinician, or who need a treatment that's going to work, a treatment app, as it were, rather than a well-being thing, which is popular with thousands of people. Most treatments are not popular.
Right.
Let's just think it that way. People don't love treatments. People don't love getting assessed and treated. Healthcare is a serious proposition, but we can help people with it. If we make it seem like a plaything, then we will not help people, and that's dangerous and deceptive.
I have a demand for health, not for treatment. Treatment is the means to get me there.
Yes.
From the perspective, though, of the people who are the managers or the leadership in the military, like in the last couple minutes here, there are hundreds of apps, right? And there are probably an equal number of other types of interventions that they can make. How should they go about choosing in a world where information isn't perfect? The marketing that Colin talks about is pervasive, right? But how can somebody decide, I'm going to use a big health app, or I'm going to use a particular intervention from the psychology literature? How do they know?
So I'm not an app expert. I've done a little bit of work in this. I do know that there are military websites that will identify sort of DoD endorsed apps that you can have on your government phone. Not every soldier has a government phone, though. That's a disparity right there. There's certainly times that we can encourage certain ways to leverage a particular app than others. And I'm not talking about treatment at all. So I appreciate, Colin, that you made that distinction of treatment apps, which have been shown to work, especially with therapist support on the other end. So I think we're still in the early stages of this, and thinking about how the apps can be used in lots of ways, not just as an individual, but leveraging the team, I think is an exciting way to move forward.
Colin, last word on that?
Yeah, I mean, I think this will all mature in time, and to me, I don't think it's complicated. I put a piece in the, I don't know if the chat, everyone can see the chat, but there's a piece I wrote there with a couple of other folk, John Torres from Harvard. It was one of the authors, and Troy Brennan from CDS Health as a pharmacy benefits manager, and it's agnostic. It doesn't mention any particular app or any particular digital intervention. It just makes the point that this isn't complicated. That things need to be proven to work if they're going to be funded out your healthcare spend, or if in the employer space they're coming out your health benefits. Then why would anyone invest in something that's not actually got evidence of benefit? If something is, we don't do randomized trials, for example, on going to school, or randomized trials on whether you have physical education at school, or advice on in the public health aspects of school education, because we just think that's the right thing to be doing. That's a public good thing to be doing, and it's interesting you create a curriculum. And I think the benefits managers need to create an interesting curriculum for the employees. But when it comes down to treatment, it needs to be recognized that that's going to be underpowered to improve someone with a health problem. And we just need to appraise and regulate these things in the usual ways like we do with any other treatments. So that article maybe summarizes better than I can say in a couple of minutes what my thoughts on it are.
Thank you so much. And we're right at 1 o'clock right now. So I just want to take this moment to thank you, Colin Espy and Amy Adler, for this wonderful discussion. It was really great to get your perspectives and to hear from your experiences. So thank you. And I just want to make one quick plug before we sign off. Our next HPHI webinar is going to be on November 18th at noon. And we'll be talking about the joys and sorrows of incorporating artificial intelligence into to healthcare delivery. So more on the healthcare side, very difficult topic. And so I look forward to hearing about that from our moderators. So thanks again to Colin and Amy, and thank you for attending, and we will sign off.